Mehta, recording this interview from the Lumen Global Meeting, and I am delighted now to introduce to you Dr. Sasko Kedev, who's been a great supporter at Lumen, has been present at various meetings. Sasko, welcome to Lumen Global.
Thank you.
I took a flight 2 days ago from Hong Kong, a beautiful, clear afternoon, which does not happen too often in this part of the world with the pollution, and I saw Mount Everest beautifully clear from the window and thought about you. You look well. For people who have not known about the beyond angioplasty life of our wonderful friend Dr. Kedev here, Sasko has climbed every peak on all the 7 continents. Sasko, unbelievable. Now, I did note that you might have to go back to Antarctica again, because one of the peaks has been discovered wasn't the highest you climbed on.
Okay, I'm not aware of this.
All right.
Some new. Not Vincent.
Yeah.
Not Vincent.
Yeah, not Vincent. Yeah. But it's a pleasure having you here. I've got a very strange question for you. So many Lumen Global meetings you've attended, so much wisdom you have shared with us. I'll get into the field of transradial and wrist access in a moment. But in all these meetings, have you had a chance to learn something too?
Yes, I think it's a multi-directional process in this meeting, particularly at Lumen, because each time we are sharing experience, we are learning. So while we are sharing, we are always learning something. We can learn from everybody. We can learn even from some junior operator. Of course, we can learn from our most experienced operators. But sharing is most important. And it was one of the most important feature of the all Lumen meetings, interactivity and sharing.
When you're talking about wrist access, what does a person like me do? I used to average 600, 700 PCI a year. I could switch quickly to wrist access and master it in 3 months. But now I do only STEMI interventions. How do you teach all these new wrist access tricks to an old dog?
I think you just need to be comfortable with access. It means with a regular puncture. To prevent crossover, knowing the anatomy of the wrist, doing some short injection during the procedure, know the roadmap, and if you know the roadmap, if you puncture, you put introducer, it's pretty much the same procedure for experienced operator. For you will take maybe 20, 30 cases, just to be more comfortable.
I believe I'm rapidly gaining that route. Talk to me about your own practice, almost 100% wrist access now?
Yes, we call it a total wrist access. Our default approach is right radial. We prefer right radial access. If we cannot use a right radial artery, we switch to the ipsilateral ulnar artery. So we use ulnar artery. If right wrist is not available, then we move to the left wrist. So it means we have at least 4 wrist arteries to use. So that was our initial strategy when we started 2007, this approach. But when we introduced a radial angiography a few years later on, we significantly decrease crossover. It is now less than 1% in
That's
our
all?
center. Yes.
Fantastic. And how do you deal with the patient with the cardiogenic shock?
Of course, for cardiogenic shock, we keep femoral artery for LV support, and we use the wrist artery.
Excellent.
Because even in cardiogenic shock, even if you cannot palpate the artery, very frequently, if you experience, you can find the relevant radial or ulnar artery with cannula. We support this puncture with cannula, not with open needle. But it's, of course, operative dependent.
Post-procedure care?
Post-procedure care is, we try to do this so-called patent hemostasis in order to decrease rate of radial artery occlusion. Bleeding is not significant issue, so now we are decreasing our compression to 90 or 200, 120 minutes. So if you perform shorter compression, not too aggressive compression, rate of radial occlusion is lower.
How much difference in the bleeding are you noticing now?
Um, of course, I started as a femoral operator, particularly in STEMI. And what is very important, we all know that bleeding and vascular complications cannot be avoided in many patients with femoral access. So femoral access is inevitably associated with a risk of bleeding and vascular complication. With radial access, this is not the issue. We can avoid all major complications, particularly vascular complications and bleeding. So bleeding complication, major bleeding is completely avoidable. The most important risk is of compartment syndrome, but with good prevention, you will not see compartment syndrome in your practice.
Now, one of the biggest advantages for the wrist access is faster ambulation, but the STEMI patient isn't really going back to work the next morning. How much has it reduced your length of stay?
So definitely a low-risk patients. It means almost all inferior uncomplicated infarctions, infarctions with good LV function can be discharged after the second day from the hospital. And what is very important, we ambulate them earlier. So it is not the same when you have a patient that can go in toilet immediately after the procedure, instead of putting urinary catheter or minor hematoma is not so benign complication. Because minor hematoma is found to be a prothrombogenic stimulus. So in femoral access, almost in most cases with STEMI, we have some kind of minor hematoma. And even this minor hematoma may play a role in further complications. This might be one of the explanation how we can discuss about the significant benefit of radial versus femoral. Minor hematomas sometimes lead to more prothrombogenic stimulus.
Right. What anticoagulants are you using, and have you changed with the going almost universally with the wrist access?
So we have not changed our anticoagulation regimen. To be honest, we never accepted bivalirudin because it was much more expensive, and it was associated with this risk of acute thrombotic complications in few proportion of our patients. So we always used unfractionated heparin. In most cases, we continue even nowadays as our antithrombotic regimen. And from dual antiplatelet, we use either aspirin and clopidogrel or aspirin and ticagrelor.
So far as you are concerned, Sasko, and the guidelines are reflecting that sentiment too. STEMI, possibly every case wrist access?
Yes, every case wrist access. But nowadays we are facing one very important problem now in our practice, because we are an academical institution. We're in charge of training of our fellows, and there are not enough femoral cases for our fellows. So nowadays we use femoral only for peripheral work, for SFA, for distal peripheral artery disease. Even iliacs we treat with radial, we treat carotids with radial, and we use femoral only for peripheral work and also for TAVI. But we are not a large volume center, and there are not enough patients for femoral training.
So how does one balance now? I mean, you know, fellows need to have, and in fact, there have been a couple of very small center studies which are now demonstrating that primarily as a result of the fellows not getting enough femoral training, the number of vascular complications from the femoral route are higher.
Yes, that's true for fellows in training. For experienced operator, it's not an issue. If you have started as experienced femoral operator and got involved in radial access, it's not problem to continue with your femoral practice in a high efficient standards. But for fellows, I believe that it could be a significant problem. That's why we are now increasing exposure to our fellows to femoral access whenever there is indication for this.
So, Sasko, you think the United States has been much behind Europe, and Asia is just fine. I mean, they have been 60, 70, 80% wrist access use. Where I remember from our earlier interactions on this area, where your experience is most unique is the much larger percentage of ulnar use, no?
Yes. We actually introduced ulnar as alternative to radial. We never consider ulnar as a default access, because ulnar artery is very elegant approach, but we have to be aware that ulnar is close to the ulnar nerve, and it is more deeply seated. So hemostasis is not so predictable like in a radial access, because there is no enough backbone support for hemostasis. Anyway, we're using ulnar as alternative. So when radial fails, then we go ulnar. And according to this experience, we decrease our crossover rate to femoral after introducing ulnar.
Right. Any particular tips and tricks to gain ulnar access?
And nowadays, there are several centers and experienced operators using ultrasound guided puncture.
Right.
In our center, we are not familiar with this technique. We have very extended experience with regular puncture of ulnar artery, but I can suggest, if you're interested, if you're interested in establishing center of excellence for ulnar, to start with ultrasound guidance.
That's what I thought. Switching topics into another area of your interest, what's the role of thrombectomy in STEMI interventions?
It's very controversial.
Yes, you're telling me?
Yes, subject. You were one of the pioneers,
yes,
even with one of the first major publications on this subject. I remember even grading of thrombus
grade.
Yes. And, but after a total trial, we have much clearer picture. But to be honest, it was not a definitive trial, because we were significantly involved in a total. We include more than 1,100 cases in our center.
Out of the almost 9,000?
Yes. No, it was 10,700.
Okay.
So around 12%.
Okay.
12%
from your center, from Macedonia.
From our center, 100% risk. There was no single femoral case in a randomized trial.
Fantastic.
So, but according to this trial, you know that this failed to show that thrombectomy has a significant advantage versus PCI alone. But it was supposed to be a routine thromboaspiration. In many real-world settings, we are aware that we do not need thromboaspiration. So let's say if you have a very distal right coronary artery, small thrombus burden, and very tortuous calcific lesion, of course, if you start doing thrombectomy, we were supposed to do it in a trial, we know that we can prolong procedure, sometimes induce some spasm, maybe even some dissection while introducing this device. On the other side, we have seen that in a large vessels with a huge thrombus burden, we have advantage of thromboaspiration. And on the top of it, there was some kind of worrying signal of higher rate of stroke. It was a higher rate of stroke associated with thromboaspiration, in total significantly.
That seems to be a lot technique related,
yes,
no?
Technique related, but what is very important, there was extremely low rate of stroke in PCI low patients.
Right.
So in a trial, in a total trial, stroke rate with thromboaspiration was pretty much the same like stroke rate in a PCI in all major trials.
So my approach for the last almost 1,200 consecutive cases has been a selective strategy based on thrombus grade. So low grade thrombus, distal lesions, small vessels, you can proceed with primary stenting. Something moderate, grade 2 to 3 thrombus, maybe patients presenting early, aspiration, and for vessels which are large thrombus burden, I still like mechanical thrombectomy, particularly with the angiojet. Make sense?
Yes, definitely it makes sense. Nowadays we are becoming more and more involved with the work of our neurosurgeons and radiologists in acute stroke. We are not default operators, but sometimes we are helping them. So we are participating with these acute stroke patients. And I'm puzzled a little bit why we never tested a device like Penumbra. Penumbra is thromboaspiration. It's very soft catheter to put distal in cerebral, distal internal carotid artery,
right.
even distal in cerebral medial artery. It's very efficient. This aspiration with this machine-derived aspiration is not like angiojet. It's angiojet is more vacuum, very aggressive device. We have never tested device like Penumbra. And if we have such a device, we can very
selectively and
selectively aspirate and very elegantly, because it is not aggressive, very flexible catheter.
Another experience I have continued to gain on Sasko has been higher and higher doses of intracoronary vasodilators, because I am convinced that and I'd like to use nitroprusside. You could use adenosine, verapamil, many other agents, and I'm using it in higher and higher doses, and just about you can gain one level of micro, MPG grade by just larger doses of intracoronary vasodilators. Have you been using vasodilators too?
Yes, we are using, but we are using as a bailout in a no reflow situations, and we try to use it more selectively, definitely with a through a microcatheter or through a thromboaspiration catheter, when we are sure that we are very distally. And I am very much convinced that it is not the same if you inject through a guiding catheter or whether you inject through a microcatheter selectively.
Sasko, always a pleasure having you at Lumen. We hope to keep you very engaged over the next 2 days, and thank you for your support for all these years.
Thank you. Congratulations again for one more great meeting.
Thank you.
Thank you.